Hello, and welcome to the Parkinson's Foundation program On the Menu, Nutrition for Parkinson's. I'm Donna Sperlakis, Senior Director of Community Engagement for the Parkinson's Foundation, and I'm excited to be here to bring our Great Lakes chapter community this education program. It seems like it's been a while since we've met, but we have been here for you all along. We're so glad you're joining us today. You are not alone, and your Parkinson's community is here with you from near and far. For those of you who are newer to the Parkinson's Foundation, welcome. We are the nation's leading community for people with Parkinson's disease, the people who love them, and all of those who are working to end the disease. With our presence in communities across the country and the globe, we believe in the promise of a cure and a better life today for those impacted by PD. The urgency of our mission really translates into what we do. To achieve our mission, we pursue three goals: ensuring better care for everyone, understanding Parkinson's through research, and educating and empowering the Parkinson's community. I encourage you to take advantage of our free resources, including our website, parkinson.org, our educational book series, webinars like this one, podcasts, our hospital safety kit called Aware and Care, our newly diagnosed kit, and of course, our toll-free helpline, 1-800-4PD-INFO, which is staffed by a Parkinson's specialist. On the research front, we invest more than $10 million annually to study Parkinson's, what causes it, how to treat it, and ultimately how to cure it. I'd like to highlight PD Generation, which is an initiative that offers free genetic testing and genetic counseling for people with Parkinson's disease. After a successful pilot program, we're thrilled to announce that the PD Generation study has launched its next step, a genetic test that can be completed at home from anywhere in the country. To learn more, visit parkinson.org/PD Generation. So how are we connecting with our communities? Your being here with us today is a prime example. It's through our centers of excellence, like the Cleveland Clinic, local chapters like yours in the Great Lakes, volunteers, advocates, and staff across the country that we bring people together to educate and empower those impacted by Parkinson's. We're also always looking for ways to keep the PD community connected. So the Parkinson's Foundation has been providing weekly education and wellness programs in a virtual format through our PD Health at Home series. Join us at an upcoming Mindfulness Monday, Wellness Wednesday, or Fitness Friday by visiting parkinson.org/PD Health. Before I introduce our speaker, I'd like to thank our program sponsor, Amneal, whose support helped to make this event possible. You should know that the ongoing support of our sponsors allows us this unique opportunity to stay connected virtually and to hear from local experts. We invite you to learn about all our program and chapter sponsors by visiting our chapter supporters page at parkinson.org/Great Lakes. And so now I'd like to introduce our speaker, Dr. Joseph Rudolph. Dr. Rudolph is a movement disorder specialist. He joined the Cleveland Clinic in 2010 after completing his movement disorders fellowship at Mount Sinai School of Medicine in New York. I'm happy to have him here today to talk about nutrition and Parkinson's. And Dr. Rudolph, it's nice to see you. From my conversations over the last couple weeks, I just want you to know that quite a few of your patients are on the call today.
Good here.
And they're all looking forward to hearing what you have to say. So with that, I'm going to turn it over to you, and you can go ahead and share your screen, and we'll put you in control of your slides. All right?
Okay.
All right, thanks.
All right. Well, very nice to be here. Thank you so much for inviting me. All right, let's do this. All right. Can you see the slides okay? Just want to make sure that it's coming through.
It looks great.
All right, very good. Okay, so today we're talking about nutrition in Parkinson's disease. This is interestingly a very popular thing for people to talk about, maybe because it's something that is actually seemingly under our control. We control what we eat, we control what we what we buy, and so and also there's a lot of stuff out there, whether on the internet or just advertisements for newfangled supplements or an amazing diet, and we'll go through and see how maybe all that glitters isn't necessarily non-fat. So let's dive right in, shall we? So we're going to start with, isn't all nutrition always important anyway? Like, why is it, what is unique about dealing with nutrition in Parkinson's? So nutrition is important for growth. Food provides the basic elements that go into all the molecules that we need to create and build on a day-to-day, second-by-second basis. Most importantly, the proteins, which are the machines of the cells, and they are the ones that do all the things that need to be done, from digestion to movement to thinking, but really all the rest of things as well. Carbohydrates, fats, and even cholesterol serve important purposes in the body. There are essential nutrients which are not part of that list above, specific vitamins. There are essential minerals, even heavy metals, which having some help the enzymes, help those proteins do their jobs appropriately. And of course, no list of what do you need to put in your mouth would be complete without talking about drinking, talking about water, and we're going to talk about hydration a bit today. We're going to keep coming back to it because it is that important. And of course, food gives us energy, right? We burn it, and that's our fuel in order to keep moving. All right. So, specific gastro issues in Parkinson's disease. Now, in Parkinson's, we have found, and by we, I mean people who are not me, have found that the GI tract is affected in a very specific way in Parkinson's. Alpha-synuclein, which is the molecule that we see go haywire in Parkinson's. Alpha-synuclein is actually a structural molecule. It helps the cell membrane of the brain cells stay as it in proper shape. That falls apart and gets collected in a little garbage can in the middle of the cell, and we see that happen throughout the GI tract, throughout the gut. We see it happen in the saliva, in the salivary glands. We see it happen in the esophagus, in the stomach, in both intestines, and even in the appendix. And the connection between that and brain problems is brought home by what has been noticed, that people who have had their appendix out are slightly less likely to get Parkinson's. That doesn't mean we all should run out and get appendectomies, because the effect is subtle and small, and it's a surgery. But it shows that there's the way to a Parkinson patient's heart is through their stomach is actually kind of legit. And what we see clinically is that sometimes the symptoms predate the motor symptoms. Every patient that comes into my office, at least if it's early on in the course, I ask about constipation. If it's late in the course, they usually volunteer it. But I ask about constipation, ask about sense of smell. There are certain non-motor features that are related to the GI tract. Constipation is the biggie. When, how bad is it? Do you have it? And it's very possible that it began before the tremor or the walking trouble or whatever. In part because these alpha-synuclein problems have already proliferated throughout the gut. Okay, so now, given that, we have some specific challenges in Parkinson's. People can get low appetite. Why? Well, maybe appetite problems are a direct symptom of Parkinson's. That's an easy answer to say, okay, if you have Parkinson's, it saps your appetite, you're not hungry, move on. It could be that, as I hinted before, Parkinson's can cause a loss of the sense of smell. And when you lose your sense of smell, that affects your sense of taste. I mean, all of us have had a cold once or twice, and when our noses are stuffed, food doesn't taste so good because it affects how we taste, right? And so in Parkinson's, without the sense of smell working at tip-top shape, maybe we lose our sense of taste a little bit, and therefore food is not that exciting anymore. We have swallowing trouble as a symptom. This we know is a direct symptom of Parkinson's. It can cause not only actual damage and actual problems like aspirating and getting food down into the lungs, but just the trouble of swallowing, the mechanism of doing the swallowing slowly and agonizingly and poorly, it makes people give up and not want to eat so much because it takes too long. It's a bit of a hassle. There can be nausea. And of course, if you're nauseated and are leaning towards throwing up, the last thing you want to do is just to stuff more food in. Constipation, this one keeps coming back up also. If you're full, you're bloated, you're less interested in eating. Beyond the act of eating, we also have molecular problems in the gut after we've eaten. So in Parkinson's, we can have difficult nutrient absorption, where we have the food is there, but it's not getting absorbed properly. Some of this might be related to the change in the gut flora. What is the gut flora? Well, we've got a lot of bacteria that live inside our GI tract. And this bacteria, this helpful bacteria, can get messed up, can get thrown out of whack in Parkinson's. And that can lead to breaking down different foods, and therefore what is available for us to absorb is different. I have a couple of patients who crave sugar, and this might be why, because their gut flora is different. There are salivary changes. Once there's swallowing trouble, or even before we notice swallowing trouble, there can be a lot of drooling. A lot of drooling doesn't necessarily make you less hungry, but dry mouth does. And dry mouth, as well as nausea and constipation, is a side effect of medicine. And so it's not only the Parkinson's itself that messes with our ability to eat, but the medicine which we're trying to give you to help. So this is a side effect. It interferes with the diet. And then, of course, once we have trouble with nutrition, trouble with getting food in, we end up with weight loss. Many Parkinson's patients just lose weight and lose weight, and it's a surprise. And it's a collection of all of these problems here. Okay, specific goals, specific things we try to do in Parkinson's. Are we looking for a cure? Is there a diet out there that's going to solve our problems? Unfortunately, probably not. Can we at least keep the disease from getting worse? Can we slow it down? The oft-sought neuroprotection. Also, probably not. Maybe a small amount. So what do we expect nutrition to do for us? Keep me healthy. Just to make sure that everything else about the body, about the person who has Parkinson's, is kept in good shape and healthy and able to go forward. That we can do. And that's what we're going to try to do. And that's what we're going to talk about today. So from the top, low appetite. How do you deal with low appetite? Well, this is mainly to the caregivers, but also to the patients themselves. If you have low appetite, you have somebody who has low appetite, don't try to stuff them a big meal. Small meals. You can eat a little bit at a time and spread it out over the day. We can talk about nutritional supplements. And at this moment, I don't mean vitamins. I mean things like Boost or Ensure or whatever. Things that offer calories and not empty calories like, a fruit drink, but useful calories. We have medicines that can stimulate the appetite. And in certain cases, we do use them. People complain, oh, I'm on Boost. I have 3 of them a day and I have 6 meals and I'm still losing weight. Like, all right, fine. So we'll try the appetite stimulant to try and make them eat more. We also have to realize that low appetite comes from other sources. Depression, which often runs along with Parkinson's. Sometimes depression is understood to be a direct symptom of Parkinson's. And in some patients, it's a little bit clear that it's not a direct symptom, it's more a consequence of the frustration and the difficulty. Or in some people, it actually predated. They were depressed already and the Parkinson's developed later. But either way, treating the depression will help might help the appetite, because appetite changes are a consequence of depression. And then we come back to the actual motor features of Parkinson's. The bradykinesia, the slow movement, that can lead to low appetite. I had one patient whose family would complain to me that he would spend 1 hour eating breakfast, 2 hours eating lunch, and 3 hours eating dinner. That means 6 hours of the day he was just sitting at the table, slowly getting his food into his mouth. He was able to do it, but it got slower and slower as the day progressed. And it was very frustrating for the family and very difficult for him. And while he persevered and kept eating for 3 hours, there are other people who would give up a little bit earlier and therefore not eat so much. So if we treat that, we might also improve the ability to eat. All right, what else? So in the mouth problems, swallowing and dry mouth. These are kind of related. We'll treat them together. Swallowing trouble, of course, anybody who's been to speech and swallow therapy knows take small bites and chew thoroughly, right? This is not, this is an almost obvious thing, but of course it does need to be said. And then beyond that, work with speech therapy. They're the experts in swallowing. They have specific exercises to practice, techniques to perform in order to relearn and to train and to how to swallow better. For more advanced people in certain locations, have electrical stimulation devices, which stimulate the muscles of swallowing, thus strengthening them. And therefore, the ability to swallow will improve that way. And the effect of that electrical stimulation will then last for a couple of months. It may need to be repeated later. Dry mouth. So dry mouth, we said, is generally a side effect, but what do we do? So drink plenty of water. Need to fight this. There's over-the-counter mouthwash. There's one called Biotine. A lot of people have tried it. It helps to some partial extent for many people. Be aware, by the way, if you have a lot of dry mouth and it's persistent and constant and it's gone on for a while, you need to work with your dentist. Why? Because dry mouth can lead to rotting your teeth and can lead to cavities and just the teeth falling apart, because the saliva kind of cleans away some of that bacteria that cause cavities and toothaches and stuff. I have a couple of patients who it progressed so far that they took out all their teeth. And while that broke my heart, the patients themselves were like, yes, it's fine. I'm happy to get it out, get it done, get the teeth out, put in implants. Great, we're done, or full dentures, and I'm so happy. But whatever the emotional response to it is, this is a very important thing that we often don't think about. And of course, medication management. Can we tweak the medicines? Can we lower certain medicines to allow the saliva to recover, to allow the dry mouth to be minimized a little bit? Sometimes we can do it. Sometimes it's a rock and a hard place type of thing. Okay, nausea. As we said, that's usually from medicine, although we've seen it from the disease itself at times. So you want to stagger your medicine from meal times. It's one strategy, so that if the nausea is temporary, so an hour after the drug, then you're ready to eat again. And so you can eat, and then your next dose of medicine is away from the meal. That is one strategy for some people. Mostly we do the other one, which is eat a little something before the medicine, usually carbs, some crackers or cereal or something, And then once there's something lining the stomach, then you can take the pill and it'll be less bothersome. That's the first round, easiest thing to do. But what if we need to adjust the medicine? What if that's not enough? So remember, Sinemet. What is Sinemet? So Sinemet is called carbidopa levodopa. Levodopa, the 100 milligram component of the medicine, this is the thing that will turn into dopamine. The levodopa gets into the gut, gets absorbed into the bloodstream, gets turned into dopamine. But wait a minute. If it turns into dopamine before it gets into the brain, it will tickle the stomach and cause nausea. That's what dopamine does to the stomach. We want the dopamine to get into the brain first, the levodopa to get into the brain first, and then turn into dopamine. So enter carbidopa. That's the 25 milligrams. Carbidopa will block that from happening outside the brain. It kind of like a bodyguard will escort the levodopa up, to the brain. Then it can convert over there. The invention of carbidopa, the introduction of carbidopa, allowed the dose of levodopa to be lowered by like 90%. The first couple of patients who were trying it were puking their guts out. And then so they invented the combination carbidopa levodopa. And then for anybody who speaks French, they called it sans emesis, without vomiting, or for short, Sinemet. Now, so for some people, even with that 25 milligrams of carbidopa, they still have some nausea. And so therefore we can get additional carbidopa. Here's our good friend Sinemet. Here's our extra carbidopa. So you see the pills are different. In fact, the carbidopa one even has the name on it. It's called low dosing. That's the brand name. So called because we're adding an extra low dose of carbidopa. This can lead to some confusion because maybe some facilities or some pharmacies or some, usually not the pharmacy, but a facility or even a hospital or a different doctor might list the medications on the med list as carbidopa, 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 and that's wrong. It should be carbidopa, levodopa, or carbidopa levodopa, entacapone if it's Stalevo. So you have to be careful that the medicines on the list are actually the medicines we're taking. Okay, for those who can't get carbidopa or because it can be very expensive, or who have tried it and it didn't work, then we take nausea medications. We can't use the regular nausea medications that are cheaper or that we give to people with migraines or pregnant women because those work opposite dopamine. Remember we said too much dopamine will tickle the stomach and cause nausea? Well, the regular anti-nausea medications will block dopamine. But blocking dopamine causes worse Parkinson's symptoms. So therefore, we need something like ondansetron, which the brand name is Zofran, that works with serotonin, that is safe, and that does not bother the Parkinson's symptoms. There are other medications, some that are not available in this country, but we all have one or two patients who go get them from Canada or wherever, like domperidone, and we do what we have to do. Cannabinoids, right? Marijuana is becoming more and more available, whether it's a cannabinoid preparation or actual medical marijuana. There are, or a synthetic one like Marinol, these can help with nausea as well. In fact, that's one of the things that it often is approved for. So that's an option for some people. All right, back to constipation, because, that's the root of all evil. So what do we do for constipation? Everybody knows what we do for constipation. Make sure you get a lot of fiber, get a lot of fruits and vegetables, including prunes or raisins. Drink plenty of water. Again, there's that drinking plenty of water. Exercising. What's the point of exercising? Well, constipation in part happens when everything just sort of sits in place, but exercise allows everything to slosh around. And so that kind of gets the gut moving. And so the food can start traversing the colon again. Surgeons use this trick all the time. After surgery, whether it's an appendix or a bigger intestinal thing, they say patient better get up and start walking so that the gut turns back on so they can get them out of the hospital. Magnesium supplements. Usually magnesium citrate is the one that's ordered for constipation, but even any magnesium preparation. In fact, I was in another country. He said, no, no, mag citrate is not the right one. It's a different one. And he and I disagreed, but whatever. I didn't push the issue. And so this can help. The milk of magnesia, which is used by hospitals and nursing homes for constipation or slow traversing. This is the same stuff. So I generally recommend to take something every day, whether it's a stool softener or magnesium supplements or fiber supplement or Miralax or psyllium husk or whatever it may be, but take something every day. Don't wait until, oh man, I haven't gone in 4 days. Well, if you haven't gone in 4 days, now you've got a 4-day long intestinal traffic jam that your laxative has to make its way all the way through. Instead, take something every day, keep things moving. If that's not enough, take something stronger, maybe every other day, just to give it a little bit more of an oomph. And if that doesn't work, take more. There's plenty to choose from, whether laxative or supplement or eventually an enema. All right. Inside the intestine, we can have some absorption issues. There's one big famous one that everybody knows about, and that's levodopa and protein. Levodopa and protein, people know the instruction, don't have protein at the same time as eating levodopa. And what I say to that, I have one detail about that, and that is try it. If you don't experience this problem, it's not your issue. In fact, I have something else to say about it. If you don't experience this problem, it's not your issue. People get very, very concerned about this, that they have to avoid any protein with levodopa. Let us explain why this is an issue at all. Imagine we have a whole bunch of amino acids. Amino acids are pieces of proteins, right? The protein goes into the stomach, it starts getting broken down into the amino acids, and the amino acids need to be brought in through the protein to the amino acid transporter to bring it into the gut wall, into the bloodstream. Now we have a lot of amino acids if you eat a lot of protein, and only one of them is levodopa. And so it's possible that levodopa will get lost in the shuffle and not be absorbed as much. But for some people, it's not a problem. They have enough transporters, or they haven't eaten a ton of protein, but they've eaten, whether it's a small amount of fish or dairy or whatever it is, that might be an okay balance. Perhaps for those people, if they have a steak, it will be a problem, or a protein shake, which is completely protein or whatever. Maybe in that case, that will be a problem, but on a regular meal or a tuna sandwich should be fine. If it is a problem, then yes, then you do your best to take your medicine not with protein, so that you get VIP treatment. The levodopa is escorted into the transporter by itself. There's nobody else, no other amino acids around to confuse the issue. Levodopa also has been reported to lower the absorption of B vitamins, and B vitamins are very important for nervous system functioning. We'll come back to supplements in the end. We'll talk about B vitamins briefly, but this is something that can happen. So here's a phenomenon that affects absorption. It's called small intestine bacterial overgrowth. Remember, we talked about the gut flora, the bacteria that live in the intestine. So what if we get the wrong bacteria to start growing in there? If the good bacteria die, then the bad bacteria will start growing. And what does that do? Well, that will naturally interfere with the absorption of the levodopa, which can lead to bad on-off fluctuations because you're not getting enough medicine, you're not getting the timing right. And just in general, the bacterial overgrowth causes an inflammatory state because the body wants to get rid of it, right? The white blood cells are there, the antibodies are there, trying to take care of this, but it's kind of perpetually on. And being perpetually inflamed is almost like having a fever all the time. And it makes you kind of sick or slightly less functional and generally unwell. So this is kind of what it looks like. It's artist rendition, right? We have the bacteria kind of just lining the walls of the gut. limiting the ability to absorb not only food, but also medication. Okay, so we mentioned the holy grail of neuroprotection. Does it exist? Can we get food that will slow down the progression of the disease? Can, this is your brain on vegetables. Can it help? The answer is, well, no, there's nothing really that we found to be that useful. What sort of things? Well, a lot of things you might have heard of include coenzyme Q10, glutathione infusions, vitamin E, creatine, as well as a bunch of other things. They've done studies on them, and they have not been found to be useful for slowing down the progression of the disease. Coenzyme Q10 in particular has been found useful in other conditions, in heart trouble, and if it's recommended by other specialists for other reasons, by all means take it. But don't waste your money taking it for Parkinson's when the effect is so minor to be impossible to see. Now, we are taught that antioxidants, right, chemicals that slow down or block the oxidation of certain things, certain chemicals in cells, are thought to be good, thought to be useful. Vitamin E, for example, is an antioxidant. But the problem is, well, which one? And we don't know. And the problem is figuring out if a specific antioxidant is good, how much, what's the dose, and is it cost effective? And we really, unfortunately, don't have a good answer yet for this. So what can we recommend? Where do we go from here? What should we do? So people suggest a Mediterranean diet. What is a Mediterranean diet? To my understanding, it's pretty much mushing together a lot of the recommended health conscious diets. Have a lot of fruits and vegetables per day. More plant food than, not plant food, but more plants than animals. Fish that are high in omega-3 fatty acids. Less dairy. We mentioned more plants than animals, so less red meat and more chicken or turkey or whatever. And even a little bit of red wine is good, but in moderation. Right? They have a cute little pyramid. And just to point out, what's important is, first of all, they also have hydration. You got to make sure you drink water. And part of the pyramid is exercise. Being physically active is its own whole realm of importance in parallel to nutrition. I'm not going to say which one is more important, but you see here it's labeled as part of the diet to be active. So I tell people exercise is actually medicine. Go schedule the exercise, go do some, because that is important for keeping the brain healthy, keeping the body healthy, so that Parkinson's does not progress as quickly as it would otherwise do. There are a few vitamins, a few supplements that we can talk about. Vitamin D has been found to be the latest and greatest in nervous system health. We know vitamin D historically is good for bone health, and I suppose that's important for Parkinson's patients who might fall and possibly break a bone. But it is also a little bit useful for energy. I had a patient with chronic fatigue syndrome. We put him on vitamin D. He says, I feel like $1 million, and we never saw him again. The maximum dose is really 5,000 units of D3. It's measured in units and not in milligrams. I don't know why. There are other doses you can take less. There's no real hard and fast rule, but this is the maximum. And for people who complain of low energy, we push it to the maximum. We mentioned B vitamins before. You can take a B complex that will include all of the B vitamins that we need. B12 is important for the cognitive function, is important for the brain and spine to talk to each other. B1 is important for cerebellar function, which is the other component of the brain that deals with coordination, not the Parkinson area, but helping the cerebellum be super healthy might help compensate for some of the problems on the Parkinson side. So maybe that's useful as well. We mentioned magnesium. Magnesium is not only a good laxative, but it helps with muscle cramps. It's a bit of a natural muscle relaxant. We even, I don't know if you still do, but they used to give it to women in early labor. They'd give IV magnesium to help shut down the early uterine contractions when the baby wasn't ready. So we mentioned vitamin E. So why is this on the list? So I'm saying don't buy vitamin E. Don't waste your money. Don't waste your time. But have foods that are rich in vitamin E. This is part of the Mediterranean diet because it's all different kinds of vegetables. Vitamin C is, of course, we know where to find that, citrus fruits, and as well as green leafies and other sources. This way you enhance your diet without wasting your money on vitamins that maybe even biologically not that helpful. The spice turmeric has this chemical curcumin in it, which helps with also with the oxidation, and some people even found a little bit of a motor improvement with turmeric. So sure, go for it. Mucunipurians is a plant that has a little bit of natural levodopa in it. So people say, "Oh, I'm eating natural levodopa. That should be better than the synthetic levodopa." I'll say, maybe not so much. Levodopa is levodopa wherever you get it. And if it's in the plant, that means there's no carbidopa, which means there's more side effects like nausea and whatever. Also, because you're eating a leaf and not a pill, the dose may be a little bit inconsistent. But to take some is fine. It's personal experience should dictate what you do after that. Probiotics, right? What can we do for that gut flora business? So taking probiotics to help restore the healthy gut flora can help fix the absorption problems, can help some of the constipation issues, can help that bacterial overgrowth thing, and maybe minimize the inflammatory problems and therefore improve the levodopa absorption. Don't go overboard with the probiotics. There are still bacteria and you can actually get sick from taking too much of them. So best to work with a gastro person as far as what to do or how much to do, more than, the basics. And here's where we hammer home, making sure you drink enough water. Why are we drinking water? Well, lightheadedness and dropping blood pressure is a symptom of Parkinson's. In fact, it's also a symptom it's a side effect of medicine. And so we have to make sure we drink plenty of water. Our little guy should remind us of this. But not only plain water, or if people for plain water is not that appetizing, you can have Gatorade, Powerade, water with electrolytes in it. Right, here's the little Miss Gatorade to remind us that having the electrolytes helps the water actually look like the blood. Right, if you drink plain water, now the blood is watery, the kidney will just get rid of it. But if you have extra electrolytes, extra salt, right, that's what electrolytes are. They are different salts. And so having the salts in the bloodstream, now the blood is saltier. So drinking the water or having the salt and water come in together, like with electrolyte water, like Smart Water or whatever. Some of those are probably scams, just water with food coloring. But, check the ingredients list. And if you see magnesium and calcium and potassium and sodium, then it's the stuff you're looking for. And having that helps the blood volume increase. So there's more blood coming to your head, making it less likely, lowering the odds of having lightheadedness. If there actually is dropping blood pressure, if you have orthostatic hypotension, you stand up and you get lightheaded because the blood pressure drops, well, we might need to do a little bit more than just drink water and actually eat salt, right? For many people with Parkinson's, salt is your friend. The entire country might be trying to cut back on salt to lower their blood pressure, but many people with Parkinson's need to raise their blood pressure. So we need more salt. There's some nutritional things like licorice or licorice tea that can also bring up the blood pressure. Beyond that point, there are actually medicines that bring up the blood pressure. But first we would talk about, okay, can we take away the anti-blood pressure medicines? Do we really need to add this? We think very carefully, but we do it if necessary. but that doesn't minimize the importance of drinking water. All right, let's take a moment to talk about brain surgery. So we see here a nice transparent person with DBS, with deep brain stimulation implanted. The effects of DBS, deep brain stimulation, what is it? It's, this is not the time to go into a whole discussion of it, but it's basically a pacemaker for the brain. The battery pack is under the skin of the chest. The wire tracks under the skin, wraps around the back of the head, behind the ear, and goes through a hole drilled in the skull into the brain, stimulating the cells that are affected in Parkinson's. Often, having DBS lowers the need for medicine. If it lowers the need for medicine, well then, now we minimize some of the medicine side effects. Nausea, constipation, dry mouth, all of these things, lightheadedness, all of these things can be less of a problem when you have deep brain stimulation. In addition, DBS often causes weight gain. And just as weight loss in Parkinson's is still a little bit of a mystery, weight gain with DBS is also still a little bit of a mystery. But it has been shown to occur. So here's the picture again, just to, in case people are curious, again, what it looks like. Battery pack under the skin of the chest, wire tracks up behind the ear and then into the head, hole drilled in the skull here, a second hole here, right? We don't necessarily need to implant both sides, but for many people, if both of your hands are busy, tremoring or stiff or whatever, then we would do both sides. Finally, I'd like to point out how nutrition alone, nutrition does not stand alone, right? We touched on this when we mentioned depression earlier. There are a lot of interconnected issues. Sleep. If sleep is messed up, well, that can lead to the diet being messed up, because let's say person gets out of bed, wanders around the house and has a midnight snack, often not a healthy one. And that affects the appetite for the next day. Or just being in general, sleep deprived. You're not so hungry, you don't want to exercise, you don't want to go forward with regular living. No, we have to make sure that the sleep is well controlled so that we can have a better day. And once there, then we can talk about, okay, let's keep the meals healthy. We mentioned depression, anxiety, similar. It can cause change in appetite, too much or too little interest in food. We mentioned this already a couple times, so we'll keep going. And of course, exercise, we mentioned that as well. All of these need to work together because food will give you the nutrients, then exercise allows you to use it, help the muscles stay healthy. That allows you to sleep better because now you have more energy during the day, so you can be tired at night, and they all work together as a unified whole, right? It's the holistic view of a patient. We're not just giving you, coming in, you have a disease, here's your drug, goodbye. But no, all of these things really need to be addressed and considered and optimized. All right, so I'd like to thank my, the whole Center for Neurologic Restoration Movement Disorder team, which includes the neurologists, the surgeons, the mental health specialists, the nurse practitioners. In particular, I'd like to single out Ellen Walter, who helped put together today's talk from our standpoint, the surgical physician's assistants, nurses, as well as everybody else who works behind the scenes in helping us function. So let's take a couple of questions here. I think there is something in the chat. Anybody?
Yeah, so we do have some questions that came in. So first of all, thank you so much. That was great information. I learned some new things, which I always like. You hear some of this so many times, so it's good to still learn. I really liked your illustration about protein and levodopa. I've never kind of seen it put that way. So that was really, I think, pretty helpful. So, so again, we did receive some questions from our audience. So we're going to go through a few of those. And for those of you who haven't submitted your questions yet, you can continue to submit those. Just click the Q&A icon in the black banner on your viewing page, and we'll try to get to as many as we can. So, so let's kick this off. And actually, this was a question I had too. So someone else was on the same wavelength as me. So you mentioned small intestine bacterial overgrowth. So how does one know they have this, and what do you do to get rid of it?
It's hard to actually really know. I guess the gold standard will be the M2A camera, where we work with a gastro person and you swallow a little pill cam, and the camera will take pictures on its way down. You do not have to retrieve it from the toilet when you're done, because all the pictures are sent, via radio frequency, email, whatever, to their computer. At least that's as far as I know, and that can help with being absolutely sure. But I suppose it's more of a clinical diagnosis, that you would work with a gastroenterologist and kind of eliminate other things that, okay, well, the nausea is not from this. We did a colonoscopy, did an endoscopy, we've ruled out some of the basic things. Maybe there's some testing of the stool that can be done. Ultimately, it really is a matter of trying to prevent it, trying to optimize your diet. And as far as the second question, which was what do you do about it? So that's where the probiotics come in. By having the healthy bacteria, you have them grow and they will push the unhealthy bacteria out of the way. One trigger for it, by the way, is having recently had an infection and being on antibiotics. Because the antibiotics will kill even the healthy bacteria that are there. And so if the timing is right, that, I had a UTI or a pneumonia or whatever it is, and I had 2 courses of antibiotics, and then for the few weeks after that, I had this bloating and discomfort, then that's a reasonable development. And so you'd want to have the probiotics often while you take high-powered antibiotics in order to prevent it.
Good. Okay. All right. So let's talk a little bit about meal timing and the type of food, or maybe it should be medicine timing, but for people with Duopa users. So is there anything that they need to consider as far as timing with meals and medications?
I would imagine either no or small meals.
Okay.
If a Duopa recipient, I would already expect nausea to be off the table, because if levodopa is not only your primary medicine, but your constant companion, then the nausea must have been optimized beforehand, that the dose is not a dose that causes nausea, or no, you're not a person who has nausea, or you've been on it long enough that nausea is no longer a problem, in which case the meal timing is less important because you're not trying to deal with that. If you're trying to be careful of the protein issue, then yes, I would say then, yeah, you wouldn't want to have a ton of protein at once, because your medicine is a constant infusion and you wouldn't want to interrupt that.
That makes sense.
What if you're going to a barbecue and that's what the meal is, it's completely protein, then fortunately Duopa gives you the option of getting a little extra burst. So you have your meal, and then you push the button a couple extra times to give yourself a boost of medicine.
Okay, good. So let's see, you mentioned magnesium. Is there an amount or a dosage that you recommend so that folks aren't taking too much, too little?
As I tell patients, I don't know that there is too much, probably diarrhea, but the typical over-the-counter pills are 200, 250, or 400 milligrams. So I often recommend just take the 400. If you have a lot of muscle cramping, then take 800. But it's usually not a big deal to take more. It also is a little bit helpful for people with migraines. So they take 800 sometimes. And if you're actually buying magnesium citrate, there'll be a dose on it for what to do for constipation.
Gotcha. All right, good. So this is an interesting question. So we hear a lot about people having problems with weight loss. or I'm sorry, yeah, with weight loss during Parkinson's. So here's someone's asking, I'm eating very carefully. I don't eat a lot, but I still can't lose weight. And this person also shared that they've also, they use a wheelchair now. They're not walking around and getting as much physical activity. So any suggestions? And maybe this is beyond, maybe that's more of a dietitian question. I don't know. But any thoughts on that?
I will say you're not alone. That as much as we talk about, and I put a big banner that weight loss is a common thing, I've had patients that go the other way. It's true. There are exceptions everywhere, and in this as well. And yeah, it can be very difficult. Um, doing your best to optimize your diet and whatever exercise one can get in, even without standing up. Chair, aerobics, etc. I don't have anything specific other than work with a dietitian and work with a personal trainer, like up the game. But it may be that there's no direct, no easy answer. You might have to, working with a doctor, working with a specialist in this, maybe a diet pill, maybe something that will cause weight loss as a medical side effect. I've got a couple of seizure or pain medicines that have weight loss as a side effect. Not a lot. Most of them have weight gain as a side effect. But people say, oh, they welcome that. But they're few and far between. But there are diet pills, and maybe some of them are acceptable. But I don't have a good answer beyond that.
Okay. Let's see, lots of stuff coming in here. What about sugar substitutes? So things like stevia, xylitol, and their effects on people with Parkinson's. Anything?
I haven't heard anything, so I will say probably not. It might have more of an effect on the constipation because a lot of these things are osmotically weirdly active. The sugar will break down and you'll absorb it, and so it's gone. But these funny chemicals will stay in the gut. They might be useful for constipation because they'll pull more water in, or they might worsen things. I don't know.
Yeah.
I can't speak to that.
Okay. Looks like we've got time for just a couple more here. Medications and dry mouth. So which medications are more likely to cause dry mouth? Is there certain ones over others that tends to be more of a problem?
The easy answer is all of them.
Okay.
Dopamine and acetylcholine, to get technical, dopamine and acetylcholine are pretty much mortal enemies, to the point of where the nausea in the stomach, for example, just to pick one aspect, the medicines that cause nausea are the pro-dopamine medicines and the anti-acetylcholine medicines. The ones that help nausea are the anti-dopamine, pro-acetylcholine. And so in the saliva, they're triggered by acetylcholine. And so the dopamine-based medicines often make those not work so well. We even have a few medicines we don't use so much anymore, except in specific situations, sometimes in younger people, sometimes in people who get tons of nausea and can't tolerate. I have had a handful of patients couldn't tolerate any dopamine-based medicine, whether it was levodopa or the dopamine agonists like pramipexole or ropinirole, couldn't tolerate anything. And we had to go to Artane or Cogentin or whatever, these anticholinergic medicines. Those will help the Parkinson symptoms and worsen the dry mouth. So you can find some medicines that we use, like for bladder control, which will be acetylcholine active. Medicines for memory are pro-acetylcholine, but they don't usually work on the saliva. So yeah, not a lot. Most of the medicines, dry mouth is a side effect.
Okay. And let's see, we couldn't have a nutrition talk without this coming up. So let's talk about the keto diet. So any benefits for people with Parkinson's, any reason to not do the keto diet? I'm thinking maybe timing with proteins. Your thoughts there?
In one of the conference talks, the keto diet was mentioned, right after the Mediterranean diet. And no, there are people who are on it successfully, and that's fine. I have no specific recommendations as far as it goes. Yeah, there are people who do just fine. There are people who do fine with the Atkins diet, right? High fat, whatever, which is kind of keto-ish. The As long as you're working with a specialist, whether it's a nutritionist or a gastro person, to make sure that you're not going on the keto diet because you like a high fat stuff because you want to live on burgers all day, then and you're doing it for the right reasons in the right way, then I would say, okay, fine, then that is an acceptable diet to choose, but I'm not the one managing it.
Right, right. All right, great. Well, those are good questions and great answers. So that is going to, I think, conclude our Q&A for today. I would just say on behalf of the foundation, Dr. Thank you again for joining us today. Thanks to all of our viewers for being here.
And thank you
I will say,
and hosting and being a great MC.
oh, thank you so much. Thank you. And I will just say, if your question wasn't answered, I encourage you to contact our helpline at 1-800-4PD-INFO, where our Parkinson's specialist would be happy to hear from you. And I'm sure if Dr. Rudolph is your doctor, you can ask him your questions as well. For more information just about our resources or our upcoming virtual events, you can visit always our website at parkinson.org. Or for a more local touch, you can visit parkinson.org/Great Lakes. This program was recorded and it will be available soon for you to view on our YouTube channel, parkinson.org/YouTube. And I've got some upcoming stuff here. And then last but not least, we do hope you'll be back soon. Our next virtual Great Lakes program will be on Friday, December 11th, where we'll be presenting Beyond the Diagnosis, Managing Changing Symptoms, and our speakers will be from the Ohio State University. And next up in PD Health at Home, on Wednesday, November 4th, is 10 strategies to thrive with Parkinson's disease right now. For a complete lineup of PD Health at Home virtual programs, you can visit parkinsons.org/PD Health. So that just about wraps it up. I do ask for you to stay on at the end of the program. A short survey will pop up, and we hope you'll take just a minute to complete it. We'd love to know what you thought and other topics that you'd like to learn about. So thank you again for joining us from Great Lakes and beyond. Stay well and come back soon.
Thank you.
Bye.
Bye.